A grayscale scan appears ordinary: bone, tissue, shadow. To a trained clinician, it may look like hundreds of other images read that week, but somewhere inside the noise, a pattern is forming, too faint for certainty, too subtle for the human eye. An algorithm marks one region in electric cyan. The question is no longer whether the machine can see, it is what exactly it is seeing. What changed when medicine gave sight to machines? To understand the future of diagnosis, we first have to understand the bottleneck. Medical imaging is one of the great achievements of modern science. X-rays reveal fractures, CT scans map internal bleeding, MRIs expose soft tissue in extraordinary detail. Retinal cameras can show the earliest signs of blindness, but every image still has to be interpreted. And interpretation is not just knowledge, it is attention, fatigue, context, time pressure, and experience, all compressed into a moment of judgment. Artificial intelligence enters this world not as a replacement for medicine, but as a new kind of instrument, one trained to detect statistical signals hidden inside pixels. The first place this pressure appears is not inside the algorithm, it appears inside the reading room. In a hospital reading room, the clinician sits before a wall of screens. One scan after another arrives from emergency care, oncology, neurology, primary care, and routine screening. Some are urgent, some are normal. Some contain a finding that is almost invisible unless the right eyes land on the right pixels at the right time. This is the diagnostic bottleneck. Modern imaging has become incredibly good at producing data. Healthcare systems have become much less good at giving every image unlimited expert attention. In many regions, there are not enough radiologists, pathologists, ophthalmologists, or subspecialists to meet demand. Even in advanced hospitals, the volume is relentless. Human image interpretation is expert work, but it is still shaped by fatigue, attention, perception, image quality, prior expectations, and crowded clinical work lists. Early computer-aided diagnosis tried to help. For decades, software searched for suspicious shapes using rules written by programmers. But those systems often produced too many false alarms. Instead of becoming trusted partners, they became another source of noise. The breakthrough came when computers stopped being told exactly what to look for. Deep learning changed the bargain. Instead of hand-coded instructions, the system was shown enormous numbers of labeled medical images: benign, malignant, stroke, no stroke, healthy retina, diseased retina. The machine did not memorize medicine the way a textbook does. It learned correlations between image patterns and clinical labels. For the clinician at the screen, this creates a strange new presence, a second reader that never sleeps, never blinks, and yet still must be questioned. So how does an algorithm learn to recognize disease without being explicitly taught the rules of disease? The engine behind much of this revolution is deep learning, especially convolutional neural networks, or CNNs. A CNN is built for images. It treats a scan not as a photograph, but as a field of numbers. Every pixel has intensity. Every region has relationships. The network searches those relationships layer by layer. In the first layer, digital filters slide across the image and detect simple features: edges, borders, gradients. In deeper layers, those features combine into textures, curves, densities, and shapes. Deeper still, the network may learn patterns associated with a lung nodule, a retinal lesion, a blood clot, or a suspicious cluster of cells. The important shift is this: the system is not looking for one human-described sign. It is constructing its own mathematical representation of what disease tends to look like. That is why AI can sometimes detect patterns that clinicians cannot easily describe. Not because it has intuition, not because it understands suffering, but because it can compare a new image against millions of tiny statistical memories formed during training. Imagine a vast digital library of medical scans. Each image carries a label given by experts. The labeled images flow into a neural network, and the network adjusts itself again and again, reducing errors over thousands or millions of examples. This is the moment medical imaging becomes more than visual inspection. Every scan becomes a dataset. Every pixel becomes evidence. Every pattern can be measured, compared, and ranked. But a probability is not a diagnosis. A heat map is not a medical decision. It is a signal. And in medicine, signals only matter when they can survive contact with real patients, real hospitals, and real consequences. The laboratory proves what a model can learn. The hospital reveals whether that learning is useful. Some of the clearest real-world examples are in time-critical care. In stroke, minutes matter. Certain AI systems analyze CT scans for signs of large vessel occlusion and alert stroke teams when a high-risk pattern appears. The goal is not to replace the specialist. The goal is to shorten the distance between scan, recognition, and treatment. For the clinician in the reading room, this changes the order of attention. Instead of every scan waiting in a simple queue, the AI can push the most urgent cases upward. In diabetic retinopathy, deep learning systems have been trained on large collections of retinal images to identify disease that can lead to blindness. The promise is especially important outside specialist centers, where screening can happen before symptoms begin and before vision loss becomes irreversible. In pathology, AI can assist with tissue slides by highlighting regions of interest, counting cells, and measuring patterns across thousands of cells at once. In some cancer workflows, these tools may help grade tumor aggressiveness more consistently, supporting prognosis and treatment planning. The pattern is the same across these deployments. AI is strongest when the task is narrow, the image type is defined, the output is clear, and human experts remain in the loop. That is why the most serious medical AI is not a magic diagnostic oracle. It is workflow technology. It triages, it flags, it quantifies, it asks the clinician to look again, and sometimes that second look is the difference. But if AI depends on data, the next question is unavoidable. Whose data taught it how to see? Medical AI can be impressive. It can also be fragile. A model trained on scans from one hospital may perform differently at another hospital using a different scanner, imaging protocol, or patient population. A model trained mostly on one demographic group may be less accurate for groups underrepresented in the data. This is algorithmic bias, and in healthcare, it is not abstract. A biased model can reinforce the very disparities medicine is supposed to reduce. There is also the black box problem. A neural network may produce a correct answer without offering a fully human explanation. Heat maps help, but they do not always reveal the reasoning. They show where the model looked, not necessarily why the model is right. Then comes responsibility. If an AI misses a cancer, who is accountable? The developer, the hospital, the clinician who trusted the output, the regulator who cleared the system for use? This leaves the clinician in a difficult new position, forced to arbitrate between professional expertise and the confident but opaque output of a machine. Medicine cannot outsource responsibility to mathematics. AI must be validated, monitored, audited, and challenged, especially after deployment when real-world data begins to drift away from training conditions. If these systems are limited, why are hospitals, companies, and regulators still moving forward? Because the stakes are too large to ignore. Around the world, health systems face aging populations, rising imaging volumes, and shortages of diagnostic specialists. The result is delay, and delay changes outcomes. AI offers a way to scale expertise without pretending expertise is simple. A rural clinic may not have a retinal specialist on site. A regional hospital may not have every subspecialist available overnight. A screening program may generate more images than humans can review quickly. In these gaps, AI can act as a force multiplier, but the deeper transformation is quantitative imaging. Traditionally, a report might describe a tumor as larger, smaller, suspicious, or stable. AI can help measure volume, texture, growth rate, and subtle changes across time. The scan becomes not only a picture, but a timeline. This points toward a future where AI does more than diagnose disease that already exists. It may estimate risk before symptoms appear, combining imaging with genomics, medical records, and wearable data. That future could be powerful. It could also be invasive, unequal, and difficult to govern. Broader orchestral texture. Sense of scale, but restrained. So the real question is not whether AI belongs in medicine. It is what kind of authority it should have. Return to the clinician at the screen. Human judgment still has to ask, does this match the patient? Does the image quality support the conclusion? Is more testing needed? Could the model be wrong? The future of medical AI should not be a handoff from doctor to machine. It should be a disciplined conversation between measurement and responsibility. Here is the thought experiment. If an AI sees a disease before any human can confirm it, is that early truth or statistical suspicion waiting for evidence? The answer will define the next era of healthcare, not machines replacing sight, machines changing what sight means. If you enjoy deep dives into the technologies shaping our future, consider subscribing to HiTechnomy. This is HiTechnomy. Look beneath the surface of the future. Join us next time as we explore another technology, system, or breakthrough shaping our world. Powered by Allergence Labs.